This narrated PowerPoint is on degenerative and inflammatory disorders of musculoskeletal tissues. Included among the inflammatory disorders of bone and joints are osteoarthritis, inflammation of the soft tissues, osteomyelitis, septic arthritis, which is sometimes called pyogenic arthritis, adult rheumatoid arthritis and juvenile rheumatoid arthritis, ankylosing spondylitis, and gout and gouty arthritis. We'll speak of each of these conditions and see how they relate to outpatient physical therapy management, as well as discuss how we need to differentiate in these conditions to determine if we can offer musculoskeletal physical therapy intervention. If we look at the diagnostic image here, this X-ray will image bone. We see a number of things going on, and one in particular is the development of an osteophyte or a nodule here at the vertebral end plate. The development of this nodule at the vertebral end plate may result in an inflammatory response that necessitates our intervention. However, if we look at this film, we consider the ABCs of radiology. A is alignment, B is bone, and C is cartilage. We note that in C, cartilage, there's a decreased joint space here between cervical vertebrae 5 and 6. As a result of this degeneration of articular cartilage, or fibrocartilage, there's more bony contact between these articular surfaces, resulting in the formation of a nodule. If this person's in the acute stage and they're recently experiencing an inflammatory response, then it would certainly fall into a inflammatory disorder. However, we'd need to question if the person's complaining of acute pain, whether this X-ray showing degeneration or spondylosis is actually what's the main source of the person's complaint. This nodule or osteophyte is actually called a Schmorl's node, letter C. And a Schmorl's node is due to an extrusion of nuclear material of the disc, which then forms a nodule, which may cause neurological related pain. Spondylosis is wear and tear. So this black arrow refers to wear and tear arthritis, which we can make that determination, or the radiologist, I should say, would make that determination because of that decreased joint space. A spondylolisthesis is a slippage of a vertebral body related to a defect in the pars interarticularis. So a slippage of a vertebrae will cause the alignment to be affected. So the first A of the first letter of the ABCs, the A refers to alignment. Here we see normal alignment. B refers to bone density. There appears to be normal whitening of bone where there should be. And C refers to cartilage, and there's decreased cartilage, but we cannot see the cartilage itself. A CT scan may infer a cartilaginous defect, and an MRI would show the cartilage. If we only consider this image, we would have to say that the above, based on the X-ray only, may be described as osteoarthritis, wear and tear, degeneration of the articular surfaces, resulting in an inflammatory response. So itis relates to inflammation. There may be disc derangement, there may be protrusion of the disc. However, we can't image the disc on the X-ray by itself. Throughout the semester, we'll talk about incidence and prevalence of disorders. Incidence is described as the frequency with which a condition occurs over a period of time in relation to the population in which it occurs. So we need to consider all those that may be potentially impacted by the condition. Whereas prevalence refers to the number of cases of a disease present in a specified population at a given time. Itis is referred to as inflammation. It's the tissue's response to irritation, damage, or injury, and it triggers a healing process. So if it's truly producing inflammatory cells, it may be described as an inflammatory disorder. As we've described previously, the 4 clinical signs of inflammation are rubor or redness, tumor or swelling, calor or heat, and dolor and pain. We need to recognize when this inflammation is present, and it may or may not be related to the musculoskeletal system. Osteoarthritis is described as a slow progressive degeneration of joint structures which can lead to a loss of mobility, chronic pain, deformity, and loss of function. So loss of mobility is something we may measure through our impairment assessment in the examination. Chronic pain is pain which is present for more than 7 weeks duration. Deformity may be a slow progressive deformity such as a scoliosis, or we may see a person with an acute deformity such as a torticollis of the neck or a lateral shift of the spine. Osteoarthritis may or may not be related to the person's chief complaint, however. But when we see degeneration of the articular surfaces and it's accompanied by a loss of function, it may in fact be the reason why the person is seeking our help. Osteoarthritis is the single most common joint disease. It's most commonly affecting the hip and knee and lumbar and cervical spine, as well as the first metacarpal phalangeal joint and the metatarsal phalangeal joints. We can distinguish osteoarthritis as primary or secondary osteoarthritis. Primary osteoarthritis is a disorder of unknown cause, and degenerative effects are thought to be related to defects in the articular cartilage. So when we see a loss of joint space on the x-ray, that could infer a cartilaginous issue. However, when we see that approximation, it could impact and relate to a person's loss of function. Secondary OA, or osteoarthritis, and that should be OA and not PA, has a known cause which may be related to a trauma, an infection, a hemarthrosis, or osteonecrosis. So if we assess the mechanism of injury, that may tell us whether traumas may be present. Infection may be more difficult for us to ascertain in our clinical examination. However, for feeling for warmth, and there's been a inoculation or there's been an open wound, then infection needs to be considered. Hemarthrosis is bleeding within a joint, and osteonecrosis, a loss of blood to a joint which leads to death of bone. So again, that's secondary OA for osteoarthritis. If we look at an X-ray film or diagnostic image, we may see in bilateral comparison a decreased joint space. So if that joint space has been obliterated or is decreased, that may infer a cartilaginous defect or a problem with the cartilage or shock absorbing capacity. It may be accompanied by loss of range of motion and loss of function and potentially a disability. If there's excessive contact between these articular surfaces, that excessive contact can cause bone to develop where it shouldn't be. And that forms a bony nodule, an osteophyte, or a spur as it's sometimes called. So again, the question remains whether this loss of joint space actually relates to the person's function. So there needs to be a correlation between the person's diagnostic imaging and their clinical exam. Here we see an X-ray of the tibiofemoral joint and patellofemoral joint. Here we see a decreased joint space between the patella and the femur, and a decreased joint space between the tibia and the femur. So it's very likely that this person has degenerative changes or osteoarthritis, because we're seeing a loss of joint space in more than one location here. And it's likely a result of wear and tear and a loss of cartilage. Here it's difficult without a bilateral comparison, but this would be representative of a decreased joint space at the acetabulo-femoral joint of the hip. And again, this could be a sign of osteoarthritis of the hip, but clinically for there to be a correlation, the person would have difficulty weight bearing. They would likely have less than 115 degrees of hip flexion and less than 15 degrees of hip internal rotation. So is there a relationship between the person's movement and the image? Age is a factor with osteoarthritis. There's a high percentage of people over the age of 60 who have some degree of articular cartilage damage, but only 15 to 20% have symptoms. So again, for our joints to begin to show wear and tear is not unusual. It probably occurs much sooner than 60 years of age. Whether the person has symptoms that are related to this degenerative change is a question. More frequently, we see osteoarthritis in males before the age of 55 and in females before the age after 55. The etiology or the cause of osteoarthritis is unknown. It's sometimes in lay terms referred to as wear and tear arthritis. It's theorized that the articular cartilage breaks down because of an imbalance between the mechanical stresses, forces, external and internal forces, and the ability of the joint structures to handle the loads. Once the cartilage begins to break down, excessive mechanical stresses begin to fall on other sites or other joint structures, and eventually fissures and eburnation. And the ivory nature of the cartilage can occur, so it becomes more dense and bone, looking more like bone itself rather than cartilage. The joint space narrows as the cartilage thins, and there's sclerosis. So sclerosis is abnormal bone formation of the subchondral bone as the new bone is formed in response to the excessive mechanical load. We see new bone forming at the joint margins, which may be called osteophytes. So this would be the lateral aspect of the knee, so we can reference the fibula. Here we see the tibiofemoral joint, which has a medial and lateral side. Here we see more contact on the medial aspect of the knee, and more separation where it's a normal joint space on the lateral side. So it's very likely this person has a varus deformity, which in lay terms is referred to as a bow-legged deformity, where we see this angulation of the knee. And it may be bilateral, or it may be more unilateral if the person's had a trauma in their earlier years. The pathogenesis of osteoarthritis may be related to immobilization. So normal healthy cartilage requires a repetitive mechanical loading and unloading for nutrition, for hyaluronic fluid to reach the chondrocytes or cells, cartilage cells, and for the cellular waste products to be returned to the synovial fluid and then the bloodstream. So we need to have this loading and unloading cycle, the invasion of hyaluronic fluid, and the removal of waste products for healthy joints. When the joint has been immobilized, then this fluid dynamic balance is no longer present. And the nutritional mechanism of the articular cartilage becomes interrupted by the immobilization when we see tissue down. You have to question when a person comes in with acute pain and they have an x-ray that shows spondylosis or wear and tear of the joints, let's say at the cervical spine. So if they can say their pain came on in June when they were lifting something, or they took a long car trip, and they have an x-ray, and the x-ray shows wear and tear arthritis or spondylosis, they probably did not develop osteoarthritis at that date in June, or around that date in June. So there may be something else going on in addition to the spondylosis that caused that acute onset of the person's acute complaint. When the onset of osteoarthritis is more gradual, that's probably more typical. It progresses slowly and gradually. The nature of the complaint, or what the person describes, would be, in quotes, a deep ache. So nature of the complaint is something we assess in the history. What's the area or location? What's the nature of the pain? How they would describe it: ache, burn, throb, knife-like pain, searing, and so forth. What's the behavior of the complaint? What makes it better or worse? Of course, what's the mechanism of injury? Is it constant or intermittent? Are also important questions as well. And then we assess the past medical and surgical history as well. In terms of osteoarthritis, the person may describe stiffness, and this stiffness may occur after they've been inactive, and maybe after they wake in the morning, or they've been sitting for a period of time, or they've been generally resting. The loss of flexibility is often associated with significant osteoarthritis disease and can occur as a secondary phenomenon to soft tissue contractures, loose bodies or cartilage breaking off, large osteophytes or spurs, and loss of that joint surface continuity or congruity. So a normal healthy joint has that normal joint space, which not only represents normal cartilage or typical cartilage, but also that cartilage provides a separation of the joint, which creates a tension load to the surrounding ligaments. In terms of treatment and prognosis, the prognosis or our prediction of the person's outcome is often dependent on the person's age, how chronic the condition is, and other comorbidities or factors that are present. So how healthy is the person? Any history of high blood pressure, diabetes, mellitus, heart problems? Those are the big three that we need to ask every patient, even if they've given us information on an intake form or on a written form in the waiting room. Our treatment intervention may involve physical agents or modalities, may involve exercises according to direction of preference. So direction of preference is that preferred direction of movement based on the person's responses to end range repeated active motions. So by asking that person to move actively and repeatedly to their available end range, we may determine if they're a preferred direction of motion. Now there may be several reasons why they prefer a certain direction of motion, but we can't argue with that as a beginning point for their exercise program. Patients with spondylosis have been found in some studies to respond very favorably to stabilization. But again, if it's stabilization of the core, and there's core muscles of the neck as well as the lumbopelvic area, those core exercises should involve no motion of the spine, of that particular spinal area that we're attempting to address. If it's strengthening, then that's movements through larger ranges of motion against a resistance. And that would be a different form of muscle contraction. Unloading may be required where we create a situation where the joints are distracted and we have the person exercise. So you may see traction apparatus over a treadmill or over a stationary bike, so that the person's receiving that distraction force while they're exercising aerobically. This too shows some promise because we're able to raise that person's heart rate, create an increase of infusion of hyaluronic fluid, removal of waste products, create a healthier environment for the joint where they're not loaded. Unweighting in a pool or pool therapy is also a form of unloading which may have some promise. Using a device where the person can exercise with graded resistance, such as a total gym, may be an intermediate step between the unweighting in a pool and the weight bearing on the person. If it's itis, there should be inflammatory cells. So if it's truly a tendinitis, the resisted isometric tests will produce pain when we resist a particular motion. If it's fairly acute and there's warmth in the area, there may or may not be redness, maybe tender to the touch. There may be an inflammation of the fibrous connective tissue connecting the muscle to bone. So the tendon's inflamed. However, tendinosis is more of a chronic tendon-related condition, which also may produce pain with resisted isometrics. However, with a tendinosis, there would be no inflammatory cells. And the treatment for a tendinosis should be different than that for tendinitis. We're trying to have the person exercising, eventually against resistance, but without reproducing that inflammatory response. With the tendinosis, that being more of a chronic contractile condition, we have to consider eccentric training and high repetition exercise in order to change the nature of that tissue. Tenosynovitis is an inflammation of lubricating fluid of the joint due to a contractile tissue involvement. So again, the resistive isometrics may be painful, but the synovium is involved, as it is in a synovitis, which is inflammation of the synovial membrane due to a damage or trauma to the cartilage or exposure to cold and dampness. So when a person describes being able to tell when it's going to rain or when the temperature is going to change, it may be reflective of a potential change in barometric pressure externally, where the pressure in their joints cannot compensate for that outside pressure change, and the person begins to feel some symptoms. So there may be some science to that complaint that we often hear from patients. A bursitis is an inflammation of bursa, which is the pad-like sac found in the connective tissue, usually in the vicinity of the joints. So for it to truly be a bursitis, it has to be inflammatory of the bursa, and often the person with a bursitis will present with an empty end field, meaning they'll feel pain before any resistance to motion is encountered by the examiner. So if we're passively moving the person's shoulder, they may feel pain during that motion of elevation as we're elevating the shoulder before we encounter any resistance to the movement. That's because at that portion of the range, the bursa may be exposed, it may be becoming compressed, reproducing their chief complaint. Osteomyelitis is an infection of the bone, and we'll discuss the pathophysiology of it, as well as its incidence and etiology, as well as some examples. The pathophysiology of osteomyelitis is an inflammation of bone, usually the bone marrow, that's caused by an infectious organism. This could be a bacteria, a fungus, a parasite, or a virus. It's usually caused by a direct inoculation into the bone. So if a person is receiving an injection. In children, the infection is spread hematogenously through the blood and usually develops in the metaphysis of the distal femur, in the proximal humor, in the radius, and it can spread, which causes joint sepsis. So sepsis or infection of the joint may occur. Vertebral osteomyelitis in adults can also spread through the blood, usually from a pelvic or urinary tract infection, and it's most common in the lumbar spine. And we may see a person who has an infection adopt an acute deformity. So an acute deformity can be mechanical or musculoskeletal, or an acute deformity could also be disease-related. When we see an acute deformity in the thoracic spine, we need to be concerned that disease or infection could be seen. Osteomyelitis occurs more often in children than adults and affects boys more than girls. Acute blood-borne osteomyelitis or hematogenous osteomyelitis is most common and is usually seen in children, whereas chronic osteomyelitis is more common in adults, particularly in those that are immunocompromised. So people who are taking drugs for immune disease, people who are taking medications for rheumatoid arthritis, these things can compromise the immune system and make them vulnerable to this infection. Antibiotics will decrease the incidence of this condition. However, we still see it in intravenous drug abuse. The cause or etiology is usually a Staph aureus. Organisms such as group B, Streptococcus, Pneumococcus, Pseudomonas, or Haemophilus influenza, and Escherichia coli also produce infections of the bone. Unfortunately, the person may not feel pain initially because of lack of pain fibers in the cancellous bone. But once it spreads to the outer surface of the bone or the compact area of the bone, the person experiences pain because there's nerve fibers in that location. The pain may be described as, again, as a deep ache. They may describe it as constant. So constant pain past the acute stage warrants special consideration on our part. We need to be concerned when it's constant and it's past that inflammatory period. It could be derangement, disruption of the contents of a joint. But deep, continuous pain, constant pain, makes us suspicious of a potential disease process. Intermittent pain is typically mechanical. Back pain may be constant and be mechanical. When it's aggravated by motion, it's described as changeable, changes with movement. If the behavior causes a change in the symptoms, it's more likely to be mechanical or musculoskeletal. Here we see an infection of the first or second metacarpal phalangeal joint. So here would be the outward appearance that we pick up in our observation, which comes as the first part of our physical exam. Here we may see abnormal bone formation in an abnormal or unusual location, a typical location, and the destruction of that bone will occur if a person is not treated with antibiotics. Lab studies are necessary for the confirmatory diagnosis. There would be an increase in white blood cells and an increase in the erythrocyte sedimentation rate, which is sometimes called the ESR. A bone scan may detect this at an early stage. So again, the bone scan is sensitive for inflammation. So it's sensitive, it's able to pick up true positives. However, it's not specific as what's causing that inflammation. But if we consider the previous slide and we see that outward appearance of an infection, the person's described an open wound. If we were to consult with a physician and recommend diagnostic imaging, the recommendation would be of a bone scan. Because if that second MCP shows up as a hotspot, that inflammation is probably infectious. However, the blood work would be necessary to determine what type of antibiotic is necessary, because it needs to be given for the specific microorganism. And the treatment is oral or intravenous antibiotics, but surgery may be indicated if the joint infection has spread to joints. Septic arthritis, or pyogenic meaning pus, has its pathophysiology as a bacterial, virus, or fungus capable of infecting a joint. Predisposing factors include systemic corticosteroids, which are often taken for rheumatoid arthritis, a pre-existing arthritis, arthrocentesis, or where blood's been drawn. A distant infection, diabetes mellitus, may be an underlying related cause, as well as trauma. People with a history of alcohol abuse or IV drug abuse, HIV, people who've had a joint prosthesis inserted, people with rheumatoid arthritis or other infectious diseases have an increased likelihood of having a septic joint. The incidence may be increasing as a result of a greater number of people with immunosuppressed conditions, and any person with an acute onset of joint pain and disability should be evaluated for possible sepsis. Septic arthritis, or inflammation of the joint, may be increasing again as a result of these immunosuppressed conditions, and as potentially the first person evaluating a person that comes into our clinic, we need to consider the differential diagnosis. So could an infectious arthritis be part of our consideration? As we saw in the picture of the person with the second MCP joint infection, there's obvious swelling, localized pain, tenderness to touch, very likely a loss of motion. When a person has constitutional signs, meaning unusual or atypical signs such as fever or chills, that's not what we typically see in a musculoskeletal setting and should warrant some concern. A child with a septic joint may refuse to bear weight, and they may be extremely tender to palpation at the joint line and along the metaphysis of the medical management of septic arthritis requires joint analysis via fluid blood work. Treatment with antibiotics such as penicillin, ampicillin, or gentamicin is required, and surgical drainage of the joint is often necessary. A more systemic arthritis and one affects multiple joints, is rheumatoid arthritis. This is a chronic, again, systemic inflammatory disease that has within joint and extra joint findings, and chronic polyarthritis meaning more than one joint, can result in severe deformity and disability. The joints of the cervical spine are most often involved, and laxity of the transverse ligament in the cervical spine can lead to subluxation of the occipital C1 joint and spinal cord compression, which could be life-threatening. So a contraindication to manual physical therapy of the upper cervical spine is rheumatoid arthritis because of the transverse ligament laxity. Rheumatoid arthritis may involve the cardiovascular, pulmonary, and gastrointestinal systems. We may also see lesions of the eye, as well as infection, and osteoporosis as other potential outside the joint manifestations. Rheumatoid arthritis may affect 1 to 2% of the adult population, and 60,000 to 200,000 children may develop the disorder. The cause of rheumatoid arthritis is unknown, but it appears to be arise from an autoimmune mechanism. And autoimmune refers to a disease produced when the body's normal tolerance of its own antigens disappears. Autoantibodies are produced when the B lymphocytes attack the normal cells, and the normal cells have a surface antigen or autoantigen, which then causes destruction of the tissue. Approximately 80% of people with rheumatoid arthritis are positive for the Rh factor. Rheumatoid factors are antibodies that react with the immunoglobulin antibodies found in the blood. Rheumatoid factors have also been found in the synovial fluid and synovial membranes of those with disease. It's hypothesized that the interaction between the rheumatoid factor and the immunoglobulin triggers events that initiate an inflammatory reaction. Leukocytes are attracted to the area, monocytes and lymphocytes phagocytose the immune complexes, creating destruction and destructive lysosomal enzymes being released, leading to articular cartilage damage, destruction, and inflammation of the synovium and thickening of the synovium. These changes can result in the development of a destructive vascular granulation tissue called a pannus. So pannus is typical of rheumatoid arthritis and is not present in osteoarthritis. This pannus can proliferate and encroach the joint space. The inflammatory cells found within the pannus are destructive, affecting the cartilage in the bone and the other periarticular tissues. The end result can be joint instability, joint deformity, or ankylosing, which is fusion of the joints. We see typical destructive phenomena in the fingers, such as boutonnieres and deformity. And often there's an ulnar drift of the fingers. We also may see a swan neck deformity. So there may be hyperextension and hyperflexion of the interphalangeal joints. The symptoms are things that the patient describes. Of early rheumatoid arthritis are stiffness that the patient describes, pain that the patient describes. He or she may describe fatigue and weakness and may be depressed. Again, psychological depression is not within our scope of practice, but it may be something that the person describes. They just don't feel like themselves. They describe pain in more than one joint. They describe general fatigue and generalized weakness. So generalized fatigue and generalized weakness are not typical musculoskeletal findings. Signs are things we may measure. We may measure for swelling, effusion, or edema. We may observe for palmar erythema or redness. The skin may actually be cool and moist. There may be muscular atrophy. Joint contraction may be present. There may be joint nodules. Synovium may be herniated, and there may be weight loss. The clinical manifestations of rheumatoid arthritis usually begin insidiously and progress slowly. Multiple joints are involved, the wrist, knee, and joints of the fingers. The involved joints may be edematous, so fluid outside the joint, warm to the touch, painful, and stiff. So stiffness may be a phenomenon measured both actively and or passively. After periods of rest, intense joint pain and stiffness, the stiffness may be called a post-rest gel. So the person feels stiff after they've been inactive. They may also experience the stiffness if they've had too much activity. So there needs to be a balance between the amount of activity they perform. They may have ulnar deviation of fingers and swan neck or boutonniere deformity of the fingers as well. So here in the swan neck, we see a hyperextension of the proximal interphalangeal joint, flexion of the distal interphalangeal joint. In a boutonniere deformity, we see flexion of the proximal interphalangeal joint, or PIP, and extension of the DIP, or distal interphalangeal joint. The diagnosis in the early stages of rheumatoid arthritis can be difficult because of the gradual and often subtle onset of the complaints. The symptoms may be intermittent, and the diagnosis is based on history, physical exam, and confirmed with blood work or laboratory tests. The American Rheumatism Association has criteria for rheumatoid arthritis. This can include morning stiffness for at least 1 hour and present for at least 6 weeks, swelling of 3 or more joints for at least 6 weeks, swelling of the wrist, metacarpal phalangeal or interphalangeal joints for 6 or more weeks, hand changes typical of rheumatoid arthritis that must include erosions or bony decalcification, rheumatic nodules, and again the rheumatic factor found in the blood work. The goals from a physical therapy standpoint are to reduce pain and maintain mobility. We can't reverse this process, but we can help maintain that person's mobility through appropriate exercise and modalities to reduce pain. We may attempt to improve and minimize the person's stiffness, reduce the edema and effusion of the joints and joint destruction, and controlling inflammation is a primary goal. So doing circumferential measurements pre and post will help determine whether our intervention may actually produce more inflammation. Non-steroidal anti-inflammatories may be used if aspirin is ineffective. And again, the risks with non-steroidal anti-inflammatories such as naproxen, naproxen, ibuprofen is gastrointestinal bleeding. Gold compounds have been shown in some studies to induce remission. Corticosteroids and intra-articular injections can provide relief of the inflammation, and often these need to be repeated. And again, the balance must be struck between an appropriate amount of exercise and an appropriate amount of rest. Too much of either can set the person back. Juvenile rheumatoid arthritis is a chronic inflammatory disease which can range from a mild illness to a severe destructive arthropathy with significant extra-articular manifestations. So unfortunately, we often see children afflicted by this condition as becoming wheelchair-bound, non-ambulatory, and hopefully they can ambulate with assistive devices. Still's disease is a form of juvenile rheumatoid arthritis characterized by a fever and a rash. And the rash typically appears on the trunk and extremities. Medications, including non-steroidal anti-inflammatories, are administered to control the systemic and joint complaints. Again, we talked about a typical versus atypical deformity in a musculoskeletal setting. When we see an increased thoracic kyphosis, that increased thoracic kyphosis can be a condition related to Scheuermann's disease, which is an inflammatory arthropathy. Or a person may have ankylosing spondylitis, which again is an inflammatory arthropathy that's characterized by thoracic joint pain as well as sacroiliac joint pain. It affects the zygoposteal joints, the facets, as well as the costovertebral and costochondral joints, and the intervertebral disc. Approximately 1/3 of those affected may have asymmetrical involvement, one side more than another, of the hip, knee, and shoulder, and the disorder can lead to fibrosis, calcification, and ossification of the joint. Ankylosing spondylitis is a condition characterized by a chronic non-granulomatosis, granuloma, inflammation. Disruption of the ligamentous osseous junction results in a reactive bone formation occurs as part of the repair process. Replacement of the inflamed cartilaginous structures by bone contributes to the progressive ossification and deformity, which can lead to a fused or bamboo spine. And long-standing disease is associated with skeletal complications and pulmonary complications because of the decreased rib expansion. The etiology or cause of ankylosing spondylitis is unknown, but a genetic or environmental link is suspected. An antigen called the HLA-B27 antigen is associated with the disease, and it's most prevalent in males between the ages of 20 and 40. So an insidious onset of thoracic and sacroiliac joint pain, maybe an increased thoracic kyphosis, symptoms in those regions without a clear mechanism should make us suspicious. The insidious onset of back pain and stiffness are often the initial complaints. The pain is described as innate, so the nature is described as innate, but occasionally it may be described as sharp. Stiffness in the morning is present. It may become worse with rest. As the more disease progresses, tolerating recumbent positions is more difficult because of difficulty breathing. Progressive disease is marked by involvement of the chest wall and the upper thoracic and cervical spine, and other complaints may include weight loss, fever, and fatigue. Here we see the increased thoracic kyphosis. This person may have thoracic pain and sacroiliac joint pain. So for those two areas which are not closely related regionally or neurologically, for the person to feel pain in those two locations is unusual. They may also have pain in the fingers or elbow, so it's not restricted to just the spine. A diagnosis is made by a history and physical exam as well as blood work and diagnostic imaging. The loss of spinal mobility in multiple planes is often seen with this condition, as is a loss of chest wall excursion. So normal chest wall excursion should be 4 to 5 centimeters, and when circumferential measurements at the fourth intercostal space reveal a decreased excursion of 4 to 5, ankylosing spondylitis may be suspected. Gout and gouty arthritis is related to an elevated level of serum uric acid and the deposition of uric crystals in the joints and soft tissues in the kidneys. Primary gout refers to too much uricemia, hyperuricemia, in the absence of other diseases. Secondary gout refers to hyperuricemia resulting from an antecedent or another disease. Crystals form inside the joints, and people at risk for urate overproduction or decreased urinary excretion of uric acid are those people with a history of leukemia, lymphoma, psoriasis, a blood disorder, hemolytic disorder, and those receiving chemotherapy for cancer. Alcohol consumption, chronic renal failure, hypertension, hypothyroidism, and hyperthyroidism can all lead to a decreased excretion of uric acid. Often this pain is felt in the first or big toe, at the metatarsal phalangeal joint, and it may be accompanied by a hallux valgus. This area may be tender and warm to the touch and extremely painful for the person experiencing this condition. The pathogenesis is characterized by sodium urate crystals precipitating from supersaturated body fluids. These crystals frequently collect on the articular cartilage, the epiphysis of the bone, and the periarticular structures. The crystal aggregates result in a local tissue necrosis, death, and a proliferation of fibrous tissue that's secondary to an inflammation of the foreign body. The incidence and prevalence is predominantly associated with men, and the family history may be associated as well. The key impairments with the tendonitis would be active motion loss, pain with resisted isometrics, tenderness at the musculotendinous junction. For it to be an itis, again, it should be in the inflammatory stage. The management depends on the stage of healing, the mechanism of injury, the amount of active and motion present, the amount of pain with the painful isometric, and the exercise needs to involve a remodeling of this tissue. A bursitis, the key impairment would be the empty end field characteristic of a bursitis, as well as that localized pain and a ruling out of other spinal conditions that may refer to the area that the bursa is located. So an L5-S1 bursitis, or L5-S1 lumbar sacral condition may refer to the lateral hip, which is the area of the greater trochanter. A C4-5 condition of the neck may refer to the lateral shoulder, or the area of the glenohumeral joint, and mimic a glenohumeral or subdeltoid bursitis.